A very good evening to all of you who have joined this webinar. I'm Dr. Rubina Rajaram, your chairperson, moderator, and one of the speakers for this session. On behalf of Jeffron Biomedical, a company that produces biomaterial and medical devices, I would like to welcome all the speakers and participants who have spared some time to attend this webinar, which is titled Liver Support Alive. This session features on clinical application of artificial liver support system, which is a very niche area in the realm of critical care in hepatology medicine. Since 1990s, various artificial liver support systems such as MARS, SPAD, and Prometheus has been developed and utilized in limited clinical practice. DPMS is another such artificial liver support system that has been around for more than 5 years. With us, we have 3 esteemed speakers, namely Professor Dr. Raki Maiwal from New Delhi, India, Dr. Ira Inductivo from the Philippines, and Dr. Leng Bai from China. These distinguished speakers have vast clinical experience with the usage of artificial liver support. Today, we hope to learn more about the practical application of artificial liver support system from these experts. I will now begin with the introductory talk titled Challenges in the Management of Advanced Liver Disease in Asia Pacific. The Asia-Pacific region is home to more than half of the global population and accounts for almost 2/3 of global death due to liver disease in 2015. According to 2015 global health estimates, liver disease caused about less than 5% of deaths in Asia-Pacific region. This table reflects the burden of chronic liver disease in Asia-Pacific region. As you can see, the Southeast Asia region, which is part of Asia-Pacific, has the highest number of years of life loss and disability-adjusted life years per 100,000 population. Advanced liver disease can cause a variety of extrahepatic morbidities, which significantly contribute to mortality. Besides an increased risk of mortality, the economic impact is high and quality of life indices are extremely low in patients with chronic liver disease. Let's look at the treatment option for these groups of patients. First, there is pharmacological therapy. With disease-specific medical therapy, when instituted, it may be able to salvage only a small number of these patients. Then, there is the option of liver transplantation, which is the definitive treatment for select group of patients. But this may not be always feasible due to shortage of suitable donors of grafts and high cost of surgery. Stem cell therapy, on the other hand, is still in its infancy stage. Next, we look at artificial liver support system, which serves as the bridging therapy to either liver transplant or till regeneration or restoration of liver function. Let's see how does artificial liver support system fit into the current guidelines of liver failure. In 2016 EASL guidelines for acute liver failure, it is recommended that extracorporeal support should be considered for those with persistent hyperammonia, for control of hyponatremia and other metabolic abnormalities, and fluid balance. Furthermore, as plasma exchange has shown to improve transplant-free survival and modulate immune dysfunction, it is of greater benefit when started early in this group of patients. Next, we move on to ACLF. In the latest APASL ACLF guidelines, artificial liver support system has been factored in as an early part of the treatment algorithm. Apart from instituting disease or insult-specific medical therapy, for those with AARC score of 10 and below, if there is no improvement of score by at least 2 points or presence of any organ dysfunction by day 4 to day 7 of presentation, bridging therapy, i.e. liver support, is strongly advocated. Whereas for the more ill patients with a score of 11 and above, with 2 or more organ dysfunction, liver support should be instituted immediately. As artificial liver support system is still not widely used in clinical setting, its benefit and side effects in real-life clinical practice is not well established. Therefore, we hope that by the end of this session, the subsequent speakers would be able to enlighten us about the practical aspects of artificial liver support system, such as patient selection and monitoring of these patients during therapy. And with that, I would like to thank you all for your attention, and I would like to introduce the next topic and speaker. So the next topic is patient selection in different kind of ALSS treatment, which would be delivered by Dr. Raki Maiwal. Dr. Raki is an additional professor of hepatology in Institute of Liver and Biliary Sciences, New Delhi, India. She has published extensively and serves as a member in the editorial board of Hepatology International Journal. Her research interest areas are critical care medicine, acute kidney injury in ACLF and cirrhosis, liver generation, and artificial liver support therapies. Over to you, Dr. Raki.
Thanks a lot, Dr. Rubina, for that introduction, and thanks to the Delvin team for inviting me for this talk. So what I'll be trying to do in the next 25 minutes is to talk about patient selection when we're doing artificial liver support system. So I hope the slides are visible. So I will talk about patient selection for artificial liver support system, and I'll be discussing that how we should be wisely choosing a patient for this form of therapy. Why are we doing this therapy? So what are the targets that we have set in, and what are the goals that we're trying to achieve? And then it also depends on what modality of artificial liver support system are we considering. And that's very important because that will also decide the choice of patients, because each therapy has a different profile of benefit and the side effect. And that's why it's important for us to understand all these points while we are choosing patients for an artificial liver support. So I'll try to enlighten the audience with the help of some case examples, which will tell us how we can choose artificial liver support. And this is the case one, and this patient was recently admitted with us at ALSS around a month back, and this patient was a case of acute liver failure. She was a 25 years old female who had hepatitis A related acute liver failure. Her jaundice to encephalopathy time was 3 days, so she had an hyperacute presentation. She had grade 4 hepatic encephalopathy and had features of severe cerebral edema on presentation. However, the King's College Hospital criteria, she met just 1 out of these criteria, but she had severe systemic inflammatory response syndrome. So she had all 4 SIRS components. She had mild shock at presentation, so her mean arterial pressure was 65, and she required a small dose of norepinephrine to maintain the MAP. She was non-oliguric with a good urine output of 40 to 50 ml per hour, and her PF ratios were poor and were below 200 at presentation. And she had already spent 5 days in an outside hospital, and she was referred to ALSS for worsening of her clinical and biochemical parameters. So if you look at the liver failure indices, so total bilirubin was just 6. The INR was also 1.72. However, she had significant renal dysfunction. Her urea and creatinine was high. Her serum albumin was low. She was septic at admission, so her procalcitonin level at admission was 11.7 at our when she presented to us. Her ammonia was 281, and her arterial lactate was 4, and the C-reactive protein at enrollment was 5. So this was the chest X-ray, which showed bibasal pleural effusion and consolidation with some basal atelectasis. And subsequently, over the course of hospital stay, when the cultures were sent, so these were the reports of the admission cultures. So she had growth of Acinetobacter and Klebsiella. So most likely she had developed a nosocomial pneumonia, and she also had a urinary tract infection. So she was given, and this is the CT thorax. So as a protocol in our institute, we do a CT imaging of the brain. And if required, if the patient has pulmonary symptoms, so we do also a CT thorax here. So this was her admission CT thorax, and we can see here, there were features of consolidation, there were pleural effusions, and this patient had a nosocomial pneumonia. So as we consider the liver involvement, she had severe cerebral edema, she has severe systemic inflammatory response syndrome, and she had already developed infections and renal dysfunction. So she was managed with broad spectrum antibiotics, which included the polymyxin group of antibiotics, as well as we also gave her hemodynamics report, lung protective ventilatory strategies. And when we consider the management of cerebral edema, that was the major challenge in this patient. So day one, she was given the supportive management. So she showed improvement in the PF ratios. They improved to 280. There was discontinuation of vasopressors. There was lactate clearance that was achieved. The lactate became normal. However, the challenge was that on day 2, she had rising levels of ammonia. She had hypertension, which was persistent. After this, she went into hypertension. She had bradycardia, and her pupils, which were initially 2 millimeter, they became 3 millimeter. They had sluggish reactions, and her optic nerve sheet diameter also showed a trend towards increase. And the optic nerve sheet diameter was 5.5 and 5.8. So what do we do next in this patient? Do we consider her for continuous renal replacement therapy? Do we consider her for her high volume or a standard volume plasma exchange, a cytokine heme absorption system, or molecular recirculation system? So any of these therapies people would like to choose. So at the end of my talk, I'll come back to this patient and show that what we did for our patient, and we can subsequently have a discussion with the panelist and with the audience of what they would like to consider. This is the second patient. This patient is a case of acute on chronic liver failure. This was a 61 years old gentleman who presented to us with acute on chronic liver failure. The acute etiology was unknown in this patient, and the chronic, he had both metabolic syndrome and ethanol. However, the last intake of ethanol was around 6 months prior to the presentation. He presented to us with an ARC score of 12, and as Dr. Ruvina had clearly pointed out, that ARC score above 11 and patient has 2 or more organ dysfunction, these patients should be considered for artificial liver support because they have a very high chance of going downhill course. The CLIF-C ACLF score is the only recommended score in context of ICU patients admitted with cirrhosis. So this also showed almost 100% mortality at admission for this patient. The SOFA score was also high. When he presented to us, he had extrahepatic organ dysfunctions. He had hepatic encephalopathy, which was grade 2. He already had a 15 days of outside hospital stay in another ICU. And the PF ratio at presentation was 189, but he was doing well with 15 days of NIV. So he had already been on NIV, so it was a kind of NIV failure when he presented to us. He had already undergone SLED 2 sessions outside, and the last session was done just 4 days prior to the admission, but he was having a non-oliguric AKI. And these were the parameters. So we can see here the INR was 2.2, the platelet was okay, the blood urea was 255, so very high urea, and the bilirubin was 16. The urine analysis had shown some crystals here. There was presence of granular CAS. The urine protein creatinine ratio was normal. The spot sodium was 10. And the urinary biomarkers also were the cystatin C was grossly elevated, but urine NGAL was less than 400. This was the chest x-ray. So this patient also had features of some capillary leak. There were bibasal pleural effusions, consolidation, and some features of volume overload. This was a CT scan which was done on admission. And here again, the similar picture was seen. So issues in this patient was, this patient had presented to us with multi-organ dysfunction syndrome. He had a failure of non-invasive ventilation, which he was already on. He had a new, most likely a nosocomial pneumonia. There was progressive oliguria with worsening azotemia and advanced uremia that he had. He required small dose of vasopressors for maintenance for renal support and had advanced liver failure. There were features of septic shock in the form of nosocomial pneumonia, and he also had bilateral lower limb cellulitis. So what do we do in this particular patient? Do we do a SLED or a sustained low efficiency dialysis? Do we consider a continuous renal replacement therapy? Do we go for cytokine heme adsorption, plasma exchange, or MARS, or just continue with standard medical treatment? So again, there are a lot of options which can be considered in this particular patient, and we'll go back to this case at the end of my talk. So what I would be like to discuss here is, while we're choosing our patient for artificial liver support, we need to identify what spectrum of liver disease are we treating. So patients may come to us where there is underlying diseased liver, that is, and the patient has acute worsening. So these patients do fairly less well with artificial liver support when it comes to complete recovery or regeneration of the liver functions. And most of the times these patients, usually artificial liver support is considered for bridging them towards a liver transplant, or bridging the organs towards recovery, or as a supportive therapy for multi-organ dysfunction in patients who have sepsis or refractory organ failures. However, if we consider acute liver failure, artificial liver support therapies look very attractive because herein the underlying liver is normal. The potential for regeneration is much higher in this particular set of patients. So again, here there is a lot of scope to use a good artificial liver support, time it well so as to achieve a complete liver recovery. So basically, if you look at the indications of using artificial liver support therapy in patients with liver failure, basically we use as an adjunctive therapy for organ dysfunction or failures, as a therapy for uncontrolled infection or inflammation due to severe SIRS, like I showed in both of my patients, as a bridging therapy towards spontaneous recovery or liver transplant, as a rescue or a salvage therapy for refractory organ failures while you're managing these patients in the ICU. And basically, we'd like to achieve the goals of achieving an immune homeostasis, improve the microcirculation, lactate clearance, improve the hemodynamics or the pulmonary, the PF ratios, and improve the outcomes if possible with the help of these therapies. Now, this is an important diagram which actually reflects how difficult it is and how you need to identify which phase of presentation or the disease the patient has presented to you. So initially, the patients with sepsis can have a very severe pro-inflammatory response syndrome, and this is a good response. This is a response of the innate and the adaptive immune system to actually handle the invading pathogen. And when it becomes very severe, this can actually result in a fulminant or a refractory septic shock and refractory organ failures, and may even culminate into death of these patients. And there is where you have to identify where this pro-inflammatory response is not good and it is beyond control, and where you need to do some form of aggressive therapy over and above the standard medical therapy to handle this aggressive response. The other is the patient may have a very aggressive anti-inflammatory response or the adaptive immune response, where they have a high anti-inflammatory markers or cytokines. And again, here it's important that we use the artificial liver support system as an adjunctive management to achieve recovery. If your patient is in the pro-inflammatory and slowly goes into second infections in the ICU or towards an immunoparalytic stage, here is where most of these therapies will not work. So timing is most important, and you have to identify your patients early on in the disease course where you should be using these therapies very wisely to handle this unbalanced or a dysregulated inflammatory response. Another very important concept in the context of cytokine response is the capillary leak syndrome. So when I discussed both these patients, I showed you that how both these patients were having significant pleural effusions, which were there. Along with pneumonia, there was extremity edema also that these patients were having. So what happens with this intense cytokine response is that you may see your patients early on, where the patient is responsive to fluid, they are hypovolemic, and you need to give colloids in these patients judiciously to see that you handle the hypoxia and the tissue injury and the necrosis of the different organs. And kidneys are the most vulnerable organs in this setting. And most of the times it becomes very important, again, in this context, to handle this aggressive cytokine response, because there is disruption of the endothelial barrier function. And to restore this endothelial barrier function and to handle this capillary leak or the interstitial edema, which is detrimental for these patients, most of the times you may like to use any of these artificial liver support therapies as an adjunctive management tool. However, while you're using these artificial liver support systems, it's important to remember that, yes, we are trying to handle this aggressive inflammatory cytokine. We're trying to resolve this or ameliorate this aggressive systemic inflammation response syndrome, whether it is due to a liver insult, maybe just a pure liver failure, or due to an infection. However, at the same time, these artificial liver support systems, when they are introduced in these patients, they can also activate the coagulation system. They may have activation of the endothelium, and the activation of inflammation can also happen, which may further propagate the DIC-like state, and it may also act like a double-edged sword. So it may even harm your patient. So that's why, with all these years of good research, people have not been able to identify whether these artificial liver support systems can improve overall survival. So this is the real challenge of how to choose your patients, because it's really very difficult. And you may see different patients in different spectrum. So it's very difficult to choose and identify which patients would benefit and which patients could actually get harmed. So while we're using, or we're trying to look for your patients, that what are we trying to achieve? What are the targets that we are looking for? What are the challenges, and where are our standard medical treatment failing? So as a help to the, or as a guidance, it is recommended that in most of these patients, what we can do is, it's okay to have a subjective parameter of organ failure or organ dysfunction, but it is always better to go with some reliable biomarker which can tell us, which can aid us or can guide us that yes, this patient has an aggressive inflammatory response and we need to do something else about it. So a dynamic monitoring with any of the biomarkers, and most of the times the studies have used either C-reactive protein, ALSS, is an emerging biomarker, and we've heard about it a lot in the context of COVID patients, which are the procalcitonin, which is again widely used in different ICUs, and serial levels give us a lot of idea about, while you're using a routine procalcitonin daily basis, can tell us about how the patient is responding to our antibiotics. The endotoxin is also a very important biomarker, which can actually tell us of using an adjunctive adsorption cartridge or a supportive therapy in these patients. Timing, I already mentioned, timing is most important, and timing also decides how your patient will fare with any of these therapy. And again, identify what is the indication, what are the challenges that you're saving. So don't try to put these therapies on where the patient is already responding, where you predict the patient may have failure to standard medical treatment. So there is where we can use biomarkers. And this was an important trial, even though it was a negative trial. It was basically done to evaluate the role of toramyxin, the cytokine hemadsorption system. The toramyxin absorbs endotoxin. So what the investigators did was they randomized patients who had a multi-organ dysfunction score of more than 9 and an endotoxin activity score of more than, endotoxin activity assay of more than 0.9, to a group which received polymyxin B, the hemoperfusion system, versus the control, the patients who were managed with standard medical treatment. They did not find any overall benefit in survival. However, when they did a post-hoc analysis, they found that patients who had an endotoxin activity assay between 0.6 to 0.9, they had actually a 10% reduction in mortality. So the very sick group may not respond. It is not right to use it in the very early group of patients. So somewhere we have to find out which patients would actually benefit with these forms of therapies. And this is our own data of our ICU of 70 patients, where we actually did an endotoxin activity assay at day 1 and day 3 and compared it with the procalcitonin levels in prediction of severe sepsis and septic shock in patients who were critically ill and had cirrhosis. So we found that endotoxin activity assay fares much better than procalcitonin in this context, and it had a better area under the ROC, and higher the endotoxin levels, the worse was the patient outcome. However, we did not use any cytokine or any form of heme adsorption system in these set of patients. So it's important again to highlight that you have to identify specifically in liver failure. It is very difficult to identify and to distinguish sepsis in patients with liver failure. So we always rely on biomarkers, we rely on cultures and other such investigations. We do not know, but yes, endotoxin was performing fairly well. And if the endotoxin levels are high and the patient has presented to you in the initial phase of response, it is better to consider in patients with acute and acute on chronic liver failure some form of artificial liver support system. And the APASL talks to us about the golden window period, and this is again about the timing, that you should be timing these therapies well on before the organ failures have set in to have a better response, because here you can regenerate the liver, failing liver. However, if you time it later, it just becomes a bridging therapy or a salvage therapy. Now we quickly go on, and I'll just be discussing the popular therapies that are being widely used only in context of patients with liver failure and whatever we are using in our ICU. So MARS is very popular, and we know that why MARS was developed over the routine forms of hemodialysis or hemofiltration is because the challenge of managing the liver patients is to handle the middle molecules and the larger toxins which are protein bound. So all these toxins which accumulate in the patients with liver failure and which are responsible for causing multi-organ dysfunction, they are not removed by the routine hemodialysis or hemofiltration. Now, there's emerging data to suggest the role of damage-associated molecular patterns which are released by the damaged or necrotic hepatocytes, and pathogen-associated molecular patterns which are required to be removed by these artificial liver support system, because these are the toxins which mediate organ dysfunction and failure in these patients. Now, MARS, I will not go into the detail because MARS therapy has not been the results have not been very encouraging in context of liver failure patients. MARS is very efficient in removing all the protein-bound toxins. It relies on the concept of exogenous albumin, which is there in the secondary circuit, and there are heme adsorbers which absorb all the protein-bound toxins. But the results of the clinical trials, both randomized and non-randomized, the summary of which has not shown a very attractive or very encouraging result. And the other challenge with MARS therapy is that it is very, very costly and it requires repeated sessions. So a costly therapy with less benefit in the overall survival is very difficult to apply on a daily basis. But yes, in a select group of patients, it can be used to handle all the, and because it is effective in not only clearing the liver-bound, protein-bound toxins, but it can also clear all the inflammatory mediators, like I talked about, the IL-6, nitric oxide, which is actually responsible for the severe vasodilatation, and all other pro-inflammatory cytokines have been shown to be clearly decreased. But the challenge is, why is it not working? Is maybe it is also reducing the anti-inflammatory cytokines, the growth factors. So none of these artificial liver support therapies are selective. So when you use them, they usually remove all the harmful cytokines, but at the same time, they are also removing the good factors. They are removing the drugs. They are removing a lot of other things, which then gets harmful for the patient. So that's the real challenge that we encounter while using. High volume plasma exchange is an attractive therapy, and results have nicely, like Dr. Rubina just mentioned about the results of the randomized control trial from Europe, which was a multicentric study, did show improvement in survival with high volume plasma exchange, which they did in these patients. And it showed benefit, the patients who were actually very sick to be transplanted, they were too sick because they had contraindications, they actually fared well with high volume plasma exchange. And we perform routinely standard volume plasma exchange in our set of patients with acute liver failure. And this is our data, the randomized control trial that we completed at our institute. And this shows that the standard volume of plasma exchange is also an effective therapy. It clears the pro-inflammatory cytokines like IL-1 beta, the IL-6, the macrophage inhibitory protein. It helps in the resolution of SIRS and improves the balance of the it improves the anti-inflammatory cytokines, and most importantly, the IL-1 receptor antagonist, which was shown to be improved. And IL-1 receptor antagonist is an important cytokine because now we know that it is also being targeted in context of alcoholic hepatitis. It competes with IL-1 beta and IL-1 alpha for their receptors. So it is a very good and protective cytokines. But at the same time, what was interesting, that we found that plasma exchange was also removing the growth factors. And this could be the real challenge. And that's why too aggressive a therapy in these patients may also become harmful. The effect on endotoxin levels we also studied, and plasma exchange was also effective in clearing the endotoxin, which remained high in the standard medical treatment group. We also found the clearance of DAMs with plasma exchange. So we studied the 6 different types of DAM molecules that were studied in this. And we found that in the standard medical treatment, we found that the levels were increasing. However, in the plasma exchange group, the levels showed a significant decrease. We also studied the endothelial function with the help of ADAMTS and von Willebrand factor antigen. And here again, we found that ADAMTS levels were shown to increase in the standard volume plasma exchange, but rather they were decreasing, again showing endothelial dysfunction, which happened in the standard medical treatment. And consequently, we also found an improvement in the 21-day transplant-free survival in this set of patients. So what we propose here is that we have to time the plasma exchange in the SIRS phase. So all these patients were considered who had systemic inflammatory response syndrome, and we did the therapy early on within 12 hours of their presentation. The intensity, we say that you should not be doing it as a very aggressive therapy. This should be based and it should be individualized and response guided. So these are 2 very important concepts that we are proposing, because we found that patients who were requiring prolonged sessions, they were not doing well. And these patients usually require a liver transplant. So patients who do well are the ones who have a response early on in these therapies. And if the patient is not responding, it is important that we consider adjunctive therapy with CRRT or other such things. We also have data in plasma exchange in acute and chronic liver failure. The results are not as attractive as in patients with acute liver failure, as I already mentioned. Here in plasma exchange did improve liver failure related death, but overall mortality could not be improved in these patients. Prometheus is another form of therapy which we were doing initially, but now we have abandoned. Prometheus fared less well as compared to plasma exchange in patients with acute and chronic liver failure, and there were largely side effects of bleeding and hemodynamic instability, thrombocytopenia, which was very severe in patients who were treated with Prometheus, and I would never recommend Prometheus for patients with acute and chronic liver failure, and we've completely abandoned this in our unit. The adsorption therapy is another attractive therapy, and there are 5 types of adsorbers that are currently available. So I've already discussed about toramixin, which is effective in clearing endotoxin. We have Cytosorb, Oxyrus, the LPS adsorber, and the HA330. So the efficacy of toramixin, Oxyrus, and Cytosorb was actually compared in this very interesting study, which was an in vitro study, where they showed that Cytosorb does not clear endotoxin. Oxyrus filter clears both endotoxin as well as the pro-inflammatory cytokines. However, the endotoxin absorbing efficiency was initially poorer in the first 30 minutes. However, at the end of 120 minutes, the absorbing frequency of absorption of endotoxin was equal for Oxyrus when it was compared to toramixin. Cytosorb was very effective in clearing all the pro-inflammatory cytokines and the anti-inflammatory cytokines. There were 27 of such factors that were studied, which were also cleared equally well with the Oxyrus. However, toramixin was not able to do so. Now, this is another interesting device, the DILIV device, which has been developed by the King's College, by the University College of London, which absorbs endotoxin and the TLR4, and it has a very high cutoff filter for extraction. There is a selective hemofiltration, and they use this device in a pig model of acetaminophen-related ALF, and they showed improvement in the circulatory and the respiratory parameters. And now this is being tried in a large randomized multicentric trial in context of acute on chronic liver failure, the results of which are awaited. This is our own experience of cytokine heme adsorption, where we used in patients with refractory septic shock, ARDS patients. Majority of these patients were on CRRT, and we can see here that we have an immediate benefit in the lactate clearance. We had improvement in PF ratios. There was a decrease in the catecholamine doses that was required, some reduction in bilirubin that was achieved. The procalcitonin levels also decreased in most of these patients. And majority of these patients, we just did one session. Most of these patients were cirrhotics, and some were patients of dengue-related ALF. The therapy was initiated in most of these patients within 8 hours, and 47% of these patients were acute on chronic liver failure. And this is the cytokine clearance of the HA330 cartridge that we found. There was an effective reduction in IL-6. There was also a reduction in IL-10 and all other pro-inflammatory cytokines that was seen in these. We have also some experience, and there is also emerging data that we can combine different forms of artificial liver support therapies. There is some data from China where they compared plasma exchange with the DPMS, and they showed plasma exchange to be more effective in clearing the IL-6 and other cytokines. And DPMS with plasma exchange was compared to plasma exchange alone. So DPMS has the challenge with plasma exchange is that there are more chances of volume overload, transfusion-related lung injury, and DPMS is safer in that context. You can use a low-volume plasma exchange, and they showed that in the later phase of the disease of ACLF, that is patients who were having advanced coagulation, a combination of DPMS and a low-volume plasma exchange fared better as compared to plasma exchange alone. This is our own experience. This is an ongoing trial where we are comparing the plasma exchange versus the bilirubin adsorption system with the standard medical treatment. These are the baseline characteristics of these patients. So we are doing this therapy in the golden window period where the patient has not gone into organ failures. And we can see here these patients are deeply jaundiced, but they have not developed any other extrahepatic organ failure. And what we found interesting results were that there were no difference in the survival. However, the new onset organ dysfunction was fairly less noted in plasmapheresis and the heme adsorption system. There was a significant reduction in the bilirubin and bile acids, and this delta reduction and a sustained reduction of bilirubin and bile acid was what was actually noted to have a survival benefit in these patients. So without therapy, if the patient were maintaining that reduction, that was causing an improvement in survival at the 28 days, which was the primary endpoint. The adverse effects were also different. We found that plasma exchange patients got more severe adverse effects when we compared. So hemoperfusion fared better with respect to adverse effects. However, because the volume overload and the lung-related problems were more encountered with plasma exchange. We also looked at the bile acid profile in these patients, and this is a busy slide just to show that we did a mass spec on these patients, and we found that the protective bile acids, so this gray bars is by plasma exchange, there is a reduction of the toxic bile acids, and this also correlated with the overall improvement in survival. So we go back to our case quickly. So what we did in the first case, the patient had severe cerebral edema. So we did a standard volume plasma exchange in this patient, and these are the parameters pre and post plasma exchange. We can see here there was reduction in the cerebral edema parameters. Even though we did not find any reduction in the bilirubin levels, CRP, there was some reduction in procalcitonin, ammonia reduced, and what happened after this is, yes, challenge with the lung. The lung was already bad in this patient, and we did find severe lung injury after plasma exchange. The patient was weaned off sedation. She had an improvement in her sensorium, but because of the lung-related issues, she was tracheostomized. And subsequently, she kept on having high fever. Fever was about 101 to 103 in the ICU. All the evaluation for fever, for viral reactivation, bone marrow, secondary HLH, we did a PET CT to rule out any other focus of infection. So this was a severe persistent inflammation and catabolism syndrome. She had capillary leaks. She had persistence of the lung infiltrates, high CRP, but a procalcitonin which was normal. So in this particular patient, we went ahead and did almost 4 sessions of cytokine heme adsorption, and these are the parameters. So she had also a rebound increase in bilirubin during her course in the ICU stay. And after the 4 sessions, we see that the bilirubin had come down, the CRP had come down. She was successfully, the tracheostomy was closed. This is a final X-ray when she was shifted out from the ICU. So she did quite well with this form of therapy. We go back to a second case of the ACLF. Here again, what we did in our patient was, we did a cytokine hemadsorption along with SLED. This patient was there and he had improvement, though he did not have such a good improvement. We did not do any further sessions because he had worsening of his platelet counts after the therapy. The platelets had dropped from 1 lakh to almost 50,000. And he did well for another 15 days, but then subsequently he succumbed to a second infection. So these ACLF patients are a real challenge to manage. So this was just a temporary benefit that we achieved by doing a cytokine hemadsorption in this particular patient. So this is just immediately after therapy, he had improvement. So basically what we were able to achieve in this patient was to avoid a mechanical ventilation. So we were able to manage this patient in the ICU without the mechanical ventilation. The urine output improved. We were able to give diuretics to further mobilize the fluid, and he was doing well, and he was successfully managed without ventilator for the next 10 days. So I'm very happy to have questions, and I'm sorry if I exceeded the time. So we can have the discussion later, I think so.
Thank you very much, Dr. Raki. We will keep the questions to the end. Thank you for the very interesting talk. In the interest of time, let's move on to the next speaker, Dr. Ira Inductivo-Yu. She's the section head of gastroenterology at National Kidney and Transplant Institute in Philippines and currently serves as the Vice President of Philippine Society of Gastroenterology. She is here to give us a talk titled Clinical Application of DPMS. Thank you.
Thank you. Okay. I would also like to thank Jaffron for inviting me to speak in this webinar. So good evening, everyone. I have actually organized my discussion to answer the following questions. What is DPMS? When and for whom is DPMS used? Why do we use DPMS? And how is it used? So to begin with, okay, when we say DPMS, it's actually just a shortened term for a double plasma molecular adsorption system. It's a non-bioartificial liver support system that makes use of resin cartridges. Now, as I've mentioned earlier, DPMS belongs under the non-biological artificial liver support system. And under this, we have hemodialysis, hemofiltration, plasma exchange, we have MARS, like Dr. Raki previously explained, and of course, we have the blood adsorption. The goal of all of these types of modalities is to temporarily replace partial liver function. Okay, now next question is when and for whom do we use DPMS? Well, basically, the basic indication for DPMS is in the management of liver failure. And as we all know, when we speak of liver failure, we mean either an acute liver failure or acute and chronic liver failure, or there's a third actually disease entity, which is basically acute decompensation. So just to run very briefly on the definition, when we say acute liver failure, we mean that there is an evidence of abnormal liver synthetic function. So there's coagulopathy, there's jaundice, there's hepatic encephalopathy, all happening within 4 weeks in a person who never had a history of liver disease. In contrast, when you say acute and chronic liver failure, you see all these hepatic insults. So the same jaundice, coagulopathy, encephalopathy with or without ascites, but this time in a patient who already had a pre-existing chronic liver disease. Now, again, as we all know, and what has been emphasized by the previous speaker, when you deal with ALF, when you deal with ACLF, you have a very high short-term mortality. People end up with SIRS, with sepsis, with kidney failure, with cardiac failure, and all of them, okay, they really have a very remarkable course. But please remember, mortality is never part of the definition of ACLF. In fact, okay, no one really needs to die just to be said that they suffered from ACLF or ALF. Now this acute decompensation, this is actually a different disease entity from an acute and chronic liver failure. But unfortunately, sometimes the distinction becomes blurred and these two terminologies are interchanged more frequently. Okay, but just for academic purposes, just to stick, okay, to the strict definition of the two disease entities, when we say acute and chronic liver failure, the presentation is actually more of hepatic. So these patients, they suffer from NSF, they suffer from jaundice. But if you say acute decompensation, the presentation could either be hepatic or they could also present with non-hepatic manifestations. So here you see patients with variceal bleeding, with AKI, okay? Now, the underlying liver pathology when you speak of acute and chronic liver failure may or may not be cirrhosis. But in acute decompensation, the underlying liver pathology is always cirrhosis. In fact, a lot of them to begin with have decompensated cirrhosis, but because there's an acute insult, they decompensate more. Now, in terms of mortality, both have high mortality, okay, but just a little bit higher in the ACL. In terms of reversal, well, the good news is that more than half of cases on the ACLF category actually had better recovery compared to the acute decompensation. However, when we speak of failure reversibility, please remember that the median time of reversal of coagulopathy is usually 7 days versus 14 days reversal time for jaundice. So if your patient recovers, you expect that they would have improvement in their PT, PTPA faster compared to bilirubin and alkaline phos improvement. So as I've mentioned earlier, really no one needs to die. Okay? Death is something that we really need to prevent. Mortality has never been part of the definition of ALF and ACLF. So the next question is, why do we use DPMS? Okay, these are the three main reasons why. Okay, because we want to prevent further necrosis of liver cells, because it's a good bridge to liver transplantation, and because we want to prevent and treat liver complications. Now, the current hypothesis suggests that a systemic inflammatory response is actually necessary to transition a patient with a stable liver state to one with a progressive liver injury and end organ failure. And when you have a lot of cytokines in the circulation, in the presence of high TNF, interleukin, CRP, you end up with a very hyperdynamic circulation. And from there, you end up with ascites, hepatopulmonary syndrome, even cirrhotic cardiomyopathy. The high cytokines in ALF and ACLF, they say is due to endotoxemia, it's due to bacterial translocation. Likewise, there is an overwhelming presence of pro-inflammatory cascade in patients who suffered from kidney injury among liver patients. Now, these are the identified retained toxins during liver failure. So you would see here that there is an abundance of both water-soluble and albumin-bound toxins. Under water-soluble toxins, you have ammonia, you have urea, you have your peptides, your interleukins, and GABA. The albumin-bound toxins, on the other hand, include bilirubin and bile acids, the aromatic amino acids, your endogenous benzodiazepines, mercaptans, and tryptophans, which also serve as false neurotransmitters and hepatic encephalopathy. So again, the toxins that is responsible for hepatic coma and cerebral edema are ammonia, mercaptans, aromatic amino acids, the bilirubin and bile acid, while the toxins that cause systemic inflammatory response include endotoxins, cytokines, and free radicals. Now, again, why do we need to use DPMS? Well, right now it's an effective blood adsorption technology. It uses a uniform resin pore structure. The physical space configuration results in a rich network structure, and the resultant physical surface area is large so that when blood passes through it, it can actually clear the small and the medium size as well as some large size toxins when they pass through the adsorber columns. Now, this is one retrospective study that was published a few years ago. This consisted of 131 ACLF Hep B patients who were given DPMS and plasma exchange. And as you can see here, there's improvement in 28-day liver transplant survival rates, as well as improvement in survival among the intermediate and advanced stage ALF patients. Now this time it used the fractionated plasma separation and adsorption system. We had 27 patients, median treatment of 3 sessions per patient. 85% of these patients suffered from ALF. And as you can see here, after a few sessions of fractionated plasma separation adsorption system, the bilirubin, the ammonia levels, they decreased significantly. The creatinine, though, more or less remained stable. Again, one retrospective study on 11 cases with acute liver failure and multi-organ dysfunction syndrome, 72% survival rate when these patients were given a combination of intensive medical treatment and DPMS. Both clinical outcome as well as biochemical parameters improved. You would see here that after several sessions of DPMS, the bilirubin, the ALTs, they dropped significantly. The albumin, the platelet counts improved also. Now, last February 2018, our institution, the National Kidney and Transplant Institute, had its first hemoperfusion. I was so happy about it. In fact, I bragged about it in my Facebook account. These were my 3 handsome angels. They are still very visible now and very supportive. Our first patient was an acute liver failure patient because of hepatitis B infection. At the time, of course, the process was not yet in place and people were just called left and right to assist. And of course, after that, people became trained, the staff became familiar with the technology, and fortunately, the succeeding operations run much more smoothly and organized. And we were able to use right now bilirubin, ammonia, and even the sepsis cartridges. Now, after that, and after a few sessions, several small meetings were held to formalize the operation of sorbent technology. So both the nephrologists and the pathologists of the institute, we convened to develop a guide on the use of sorbent technology. And April 2019, we were able to release its manual. It became a good guide, not only to the doctors within the institute, but also outside the center. So right now, we are using sorbent technology for CKD patients, for sepsis, for bilirubin, for ammonia. Now, the current usage right now of DPMS is in the treatment of acute liver failure, in the treatment of acute and chronic liver failure and acute decompensation, and as a bridge to liver transplant. We have attended to quite a few of these patients who suffered from these 3 main indications. But we have also extended the use of DPMS to the following: patients with primary liver malignancy or liver metastasis prior to their chemotherapy sessions, patient who had post-hepatectomy liver failure and post-cardiac surgery liver failure. And 2 years ago, we have also extended it to some severe leptospirosis patients. Now, I'm sure a lot of us have handled patients who underwent cardiac surgery, and most of these patients, they don't have really very severe liver impairment. In fact, the mortality after a cardiopulmonary bypass is really low. But some patients, unfortunately, develop end organ damage. And if you develop an acute liver failure, unfortunately, the mortality rate could be as high as 90%. There are several mechanisms for post-operative liver dysfunction, but the most significant of this is a decreased hepatic perfusion during the operation itself. Now, this is a study that emphasized that there is actually a good role of adsorption therapy post cardiac surgery liver failure. So as you can see here, the bilirubin, the ALT, they improve. So it could be considered as part of a combined intensive care in patients who develop acute liver failure after a major cardiac surgery. I had 2 personal experience at the Philippine Heart Center. Patients develop severe liver impairments with ALTs as high as 5,000, with bilirubin as high as 20 to 30 times the upper limit of normal. One patient had a multi-vessel bypass surgery. One patient had a valve replacement surgery. And after 3 to 5 sessions of DPMS using bilirubin and ammonia cartridges, as well as the sepsis hemoperfusion, because these patients also had severe sepsis, Both patients were able to make it. They were discharged after a few weeks, and presently they are living productively. So this, again, we've used DPMS for some patients who just cannot be started by the oncology people with their chemo drugs. Okay, this is a list of the common chemotherapeutic agents that just cannot be used left and right if there is severe liver dysfunction. So some patients we subjected to bilirubin hemoperfusion until the bilirubin levels become acceptable so that their chemotherapy could either be initiated or continued. You can also use it after a local regional treatment with severe liver impairment. Again, the number of sessions will depend until you achieve your goal, which normally is a bilirubin, okay, less than or equal to 5 milligrams per DL. Now, last 2018 again, okay, our institute became a big referral center, okay, for severe leptospirosis patients. In fact, we have to convert our gymnasium to a very big leptospirosis ward to accommodate for 136 wheels patients. So these are patients with jaundice, renal failure, and pulmonary hemorrhage. And because we've been having left and right severe lepto patients, we had to somehow modify our treatment protocol. So for patients who had pulmonary hemorrhage, they were given ECMO. For patients who had severe sepsis, they received a few sessions of the sepsis hemoperfusion. So this is how toxic the patients look like. This is just a sample of some patients who were given the hemoperfusion. So patients who develop sepsis, they receive few sessions of the sepsis hemoperfusion. There is subsequent decrease in procalcitonin. This is one patient who developed severe hyperbilirubinemia, had been subjected to bilirubin hemoperfusion with subsequent decrease in the bilirubin level. Another patient who became encephalopathic, ammonia level went so high, so he received the ammonia hemoperfusion. This is one patient who received both the bilirubin and the ammonia hemoperfusion because he has been having very severe liver dysfunction and subsequent improvement in the liver parameters. Now, last question is, how is DPMS used? Now, this is the most simplistic, okay, explanation on how DPMS is used. Whole blood is passed through a plasma filter, and then it is circulated in a sorbent cartridge. This sorbent cartridge could either be your ammonia cartridge, could either be a bilirubin cartridge, could either be a sepsis cartridge, or it could be a combination of both. And then after the sorbent unit, the plasma is returned to the blood circulation. Now, how do you use it? Well, you remember you are dealing with a liver failure patient, and therefore it is never a one-man team. So specifically for DPMS, the required subspecialist, of course, should be a gastroenterologist or hepatologist. Please always refer to your nephrologist because they are the ones who are really familiar with the dialysis machine. You need to refer to vascular people or intensivists to put in the access, okay, for the machines. And then you need to rely on a very trained dialysis nursing staff and technician. So how do you use it? Again, you cannot use it through a peripheral line. You need to have a central access. So it's either an IJ cat or a femoral cat, or if your patient already has a pre-existing AV fistula or AV graft, then that will do. If you're using a bilirubin cartridge, you need to have a CRRT machine. If you're using purely an ammonia cartridge, then a regular hemodialysis machine will do. But if you want to combine, you want to use DPMS, then you need to have CRRT. Now, how frequent do you give it? Every 2 to 3 days until goal achievement. So which means until bilirubin drops to what you think is comfortable with you, but based on guidelines, it should be less than 5. You do it until hepatic encephalopathy falls down to grade 1, grade 2 level, or you do it until there's resolution of pruritus. Now, how long do you give, or how long do you hook your patient to the machine? Usually 2 to 3 hours, okay? Now, do you always transfuse blood products during hemoperfusion? Only if the platelet is less than 75,000 or the INR is more than 1.5 or there is presence of pedicare or hematoma. These are our recommendations, but as you see, we always emphasize that the frequency, the duration, okay, the indication should always be individualized. So as take-home points, again, let me answer the questions that I posted on my first slide. What is DPMS? Well, it's an artificial liver support system that absorbs ammonia and bilirubin and inflammatory mediators and cytokines. When and for whom is DPMS used? It is used for patients with severe liver impairment and liver failure. Why do we use it? Because we want to improve the prognosis and the survival rate among our liver failure patients. And how do we use it? It is done every 2 to 3 days until goal achievement, either via CRRT or regular hemodialysis machine with the right team. Now let me end my talk by quoting again what I have put last February 5, 2018 in my Facebook account. I have used this a lot of times on my lectures. I have never get tired of sharing it because this is really true. And I must thank the father of modern transplantation for this nice quote. That the history of modern medicine is what was inconceivable yesterday and barely achievable today often becomes routine tomorrow. So thank you. We will again entertain question and answers after the last speaker. Thank you. I think we can move on to the moderator to introduce our last speaker, Dr. Lang. Or should Dr. Lang take over? Dr. Rovina? Much as I want to introduce Dr. Lang, I just cannot. I don't have his extensive resume.
So what happened?
Dr. Rovina. Okay, should we go on to the next speaker?
Yeah.
So now let's welcome Dr. Lan to his presentation.
Okay. Okay, so hello everyone. First, I'd like to thank Dr. Romina for her introduction. So I'm pleased to have this chance to share my experience about the anticoagulation in ALSS treatment through webinar. So I will talk about something about the anticoagulation in a artificial liver support system treatment. So firstly, as you know, so there are many patients with liver failure caused by virus infection, alcohol, and drugs all over the world, especially in China. So we have, because of HPV and HCV infection, so we have to face more acute and chronic liver failure patients. So here I just show you the clinical characters of acute and chronic liver failure, such as the increased total bilirubin and the decreased DT activity and or NR. So maybe the patient will have should be have the jaundice. So usually we have the three treatment measures to treat this liver failure patients, including internal general treatment. So we have to use different drugs to treat these patients. And also if we have this ALSS device to start the ALS treatment, just like the Dr. Ira said that if we have the DPMS device, so maybe we can start the ALS treatment. So, and if ALS treatment does not work, so maybe the liver transplantation is the last hope for this liver failure patients. So actually, the artificial liver support system is essentially a blood purification treatment. So we can use this extracorporeal circulation device and to finish the blood purification. And this system can remove all kinds of toxin due to the liver failure. And if we use this plasma exchange, so maybe this models can supplement the protein and the coagulation factors. And also, to some extent, it can maintain the internal stability. And so the ALSS can temporarily replace the liver function during the hepatocyte regeneration or liver function recovery. And so here I just show you this carton. And so the patient's liver just like this baby, it's very weak, and so it needs the ALS help. And so on this slide, I just show you the different ALS modes, and such as plasma exchanging combined with or not combined with CRT, and plasma absorption combined or not combined with CRT. And also usually we use the albumin dialysis like Mars. So doctor need to select the suitable ALSS modes according to patient's actual condition. So we know our liver plays an important role in the regulation of the body's normal coagulation function, and the many proteins related to coagulation function are synthesized in the liver during liver failure due to extensive damage to liver cells. So insufficient synthesis of procoagulant and anticoagulant factors and disorders of the fibrinolytic system, and insufficient synthesis of thrombopoietin will exacerbate the coagulation dysfunction. So because of disorders of coagulation in patients with liver failure, and ALSS extra corporeal circulation requires anticoagulation. So anticoagulation technology must be a very important technology in the treatment of ALSS. So I think the anticoagulation effect directly affects the occurrence of bleeding and other complications, and the success rate of ALSS and the efficacy of ALSS, and even the mood of the patients and their families, and the trust in doctors. So what factors will affect the anticoagulation effect? I think many factors will influence the anticoagulation effect, just like that I listed here on this slide. The factor from patients, from nurse, from doctors, and even from equipment. Some factors that we cannot change in, but some factors that maybe we can adjust it through according to the patient's conditions. So here I think the anticoagulation protocols is very important. So now we know the anticoagulation of ALSS is necessary and very important. So next we should clearly understand the objectives and the principles of anticoagulants used in ALSS. This question determines that what kind of anticoagulant the doctor should choose, the dosage, and how to adjust it during treatment. During ALSS treatment, we should minimize the activation of the coagulation system by the therapeutic membrane and the tubing to maintain the effectiveness of the filter and the tubing for a long time. And we also it is best to minimize the incidence of systemic bleeding. So this anticoagulation effect is it is best to limit the anticoagulation effect to the extracorporeal circulation and has the least effect on the patient's coagulation system. So compared with CRT, the ALS treatment, I think is difference. So during the ALSS, so we know that the blood flow is lower and the treatment time is shorter, and also we have to consider disorders of the coagulation system in patients with liver failure. So that means it is best to implement individualized anticoagulation protocols and reduce the dosage while ensuring the effect as much as possible. And we should and we can adjust the dosage at any time if we want to adjust. And if the emergencies occurs, that we can terminate the anticoagulation in time. So So here I list the characteristics of ideal anticoagulant, including small dosage, non-effective time to maintain the effective time of extracorporeal circulation, and it will not affect the systemic of the blood filter membrane, and also it has strong anti-thrombotic effect, and it has no bleeding risk, short acting and limited to the extracorporeal circulation, and the monitoring method is simple and easy. It's suitable for bedside, and for this anticoagulant, we should have the antagonist to fight against overdose, and also the price is cheap. So I know we have no anticoagulants that can meet all that above condition currently. However, we should consider the characteristics and the requirements as comprehensively as possible when we face to choose anticoagulants before we start ALS treatment. So in clinic, we used to choose heparin, no molecular weight heparin, and agatroban and regional citrate to be anticoagulation technology. Also, I know some doctors would like to choose anticoagulant free during ALS treatment. Today, I will mainly introduce the heparin and the regional citrate anticoagulation. So because most of hospitals use the heparin as the anticoagulant, so in our center, we used to use heparin to be anticoagulant, but now we try to use regional citric acid to be an anticoagulant in ALS treatment. So the main mechanisms of heparin coagulation is that it can combine with antithrombin 3 to accelerate the inactivation of factor 2A and 10A. So this complex or this process, it can inhibit platelet adhesion and aggregation. And the heparin average molecular weight is 150 kb. And the heparin heparin is mainly metabolized in the reticular endothelial system. A small amount is metabolized by the kidney, and the heparin's pharmacokinetics are unstable, and the half-life after intravenous injection is 23 minutes to 2.48 hours, so which is related to dose and varies greatly. And usually we can detect the APT or ACT to monitor the effect of heparin. And on this slide, I just show the heparin anticoagulation protocol we often use during plasma exchanging. So we adjust the first dosage and maintenance dosage according to the PTA of patients with liver failure. So for example, when the PTA is lower than 20%, usually we do not use heparin anticoagulation because in China, the blood center usually use citric acid to save fresh plasma. And in addition, the patient's coagulation function is extremely poor. So we usually do not use heparin, but we are monitoring. We will still monitor closely during treatment when the transmembrane pressure increase and there is a strong burst in the venous part. We will add some heparin to blood circulation, and so here I just to show you this on this slide. I just show you the heparin anticoagulation regimen during DPMS. So we still adjust the heparin dosage according to the patient PTA because no plasma used in DPMS. So if a patient's PTA is lower than 20%, the first dose of heparin is 20 microgram, and then maintaining dose is 5 milligram per hour. And so considering the DPMS is a absorption-based model, so it will cause the platelet decrease. So we also need to adjust the heparin dose according to the patient's platelet count. So here I just show you if this patient's platelet is higher than 225, so we should to increase the first dose, increase 40 milligram, and the maintenance dose also increased to 10 milligram per hour. So for heparin anticoagulation, so for here I just show you the advantages, its advantages and disadvantages. So the advantages is it's a classic mature technology, and its effect is significant, and it's easy to monitor. It's easy to monitor, and the half-life time is short, and it can be neutralized by protamine, and the price is cheap also. And they also we have here I just to show the disadvantages of heparin, such as the high risk of bleeding, heparin-induced thrombocytopenia, and we know the heparin's anticoagulation depends on anti-thrombomin, anti-thrombin 3. Most of critical patients lack of these factors, and also this anticoagulation particularly the frequent monitoring, and some patients is allergic to heparin. So despite this, I think the heparin is still the most commonly used anticoagulant for artificial liver treatment, and I think that the most important issue is that we need to establish the individualized or personalized heparin anticoagulation regimen. So except the heparin and the no molecular weight heparin is another choice for anticoagulation. So the no molecular weight heparin is isolated from unfractionated heparin, and also its mechanism is the same as the heparin, and it is many metabolized in the reticular endothelial system, or small amount is metabolized by the kidney, and we should monitor anti-10A factors during using low molecular weight heparin to anticoagulant. So for this mode of anticoagulation, I think its advantages is its stable pharmacokinetics and no need monitor, and the effect is good, and no incidence of head. And its disadvantages, its risk of bleeding and easy to accumulate when kidney failure, and the no molecular weight heparin is only can be partially neutralized by protamine, and the half-life is longer than heparin, and so usually the anti-10A factors is not easy to monitor. So for agatroban anticoagulation, I do not want to talk about it because we rarely use an agatroban as anticoagulant in ALS treatment. So I also have no experience to share with all of you. But I know in some hospital and some doctors, I would like to choose the agatroban to be anticoagulant during ALSS treatment. So I think if you have any experience about this mode of anticoagulation, I think maybe you can share with us. So at last, I'm pleased to share my experience of using citric acid in ALS treatment. Here is for healthy people, the sodium citrate can be completely metabolized in 30 minutes. Its half-life time is about 5 minutes. So the regional citrate anticoagulation is the infusing of citrate into the blood circuit during treatment. It can chelate ionized calcium, forming calcium citrate complex. So this complex can prevent the coagulation of blood due to citrium is required for the generation of thrombin. The optimum citrium ion concentration in vitro is 0.2 to 0.4, and in vivo is 1 to 1.2. And so just like just like I showed here, this picture, the sodium citrate is pumped into the blood through leading end of catheter for anticoagulation in vitro. The calcium glycinate is pumped into the blood through return this end of this return end to restore blood coagulation. So this RCA is used in CRT anticoagulation for more than 20 years, and I think its advantage is no risk of bleeding, no incidence of hit. I think this is very important for us to choose this anticoagulation during ALSS treatment. And also RCA also has its complications, including citric acid accumulation, metabolic alkalosis, hypercalcemia, and hypernatremia. So, although RCA is widely used in CRT treatment, we should realize that it still has contraindications, including severe hypoxemia, poor tissue perfusion, abnormal liver function, and because under these contraindications, the citrate metabolism is reduced and its accumulation risk increased. So if having any of three is a relative contraindication, having any two or more of the three is a absolute contraindication. So here I just show the ratio of total calcium to ionized calcium is a good indicator for citric acid accumulation. If this ratio is higher than 2.5, that indicates a citrate accumulation. So because of the total bilirubin of the patients with liver failure must be higher than 2 times normal upper limit. So that means there are one contraindication of RCA in liver failure. So we have to think if liver failure patients can use RCA as an anticoagulant. So here is a research about the citric acid metabolism in patients with cirrhosis. From this research, we can find that the metabolic consequences of citrate infusion were not different between groups in this study, and so that it indicates citrate anticoagulation seems feasible even in patients with decompensated cirrhosis. And also, we designed a research about the citric acid metabolism in patients with acute and chronic liver failure. So this is a prospective observational study, and we observed the citrate accumulation due to plasma exchange among patients with ACLF. So here, I from this table, we can see that that no patient has citric acid accumulation before PE, and 100% patients have citric acid accumulation immediately after PE, and about 30% patients have citric acid accumulation 1 hour after PE, and it is interesting that no patients have citric acid accumulation next morning. So next morning, and all of the patients are well tolerated. So in this prospective of the observational study, we found that the citric accumulation due to PE occurred in all the patients with HBV ACLF who received the plasma absorption and the PE, but did not receive filtration or dialysis, and it has well tolerated. Further, I think the further research should be carried out to assess the safety and efficacy of RCA for PE-based ALSS therapy in patients with liver failure who do not receive dialysis and filtration. So here, we just think is it possible to try citric acid accumulation during ALSS. So this is our another research we just designed this research to observe the safety and the efficacy of regional citrate anticoagulation during plasma absorption and plasma exchanging therapy for patients with acute and chronic liver failure. So we just divided this patients into two different groups. One is HA group, who using the heparin as the anticoagulant, and another group is RCA groups who using the regional citric acid as an anticoagulation. So here, from this table, we can see that the RCA still has a good anticoagulant effect compared with the HA group, and the RCA does not increase the mortality, complications, and hospitalization days. So also we can find the transient accumulation of the citric acid. 100% patients have no accumulation of citric acid next morning. So and the patient's acid base nutrition to acid base is not status has not been greatly affected. So we also from 217 and to 219, more than 200 cases of regional citrate anticoagulation were implemented in ALS treatment in our department, in our center. So I think so our practice has confirmed that RCA could be used for a blood purification treatment of liver failure patients. So in the end, I would like to thank my team members, Dr. Ma, Ms. Xu, Ms. Chen, Ms. Zhou. Thanks to our team members for their contribution and their work to our research and our works. Okay, so that's all. Thank you. Dr. Luna, I'm finished.
Thank you very much, Dr. Lang Bai. This is Dr. Lang Bai, and he is the Deputy Director of Center of Infectious Disease, West China Hospital, Sichuan University. He also holds portfolio as a young member of Liver Disease Branch of Chinese Medical Association and member of Liver Failure and Artificial Liver System Group, Liver Disease Branch of Chinese Medical Association. That was a very excellent talk, Dr. Lang. So in the interest of time, let us move on to the discussion and question and answer sessions. So I would like to get the ball rolling by asking a few questions. Can one of you comment on the safety and efficacy biomarkers for evaluating the artificial liver support system therapy when patient is on these ALSS?
Yeah, can I take that up? So I discussed
Definitely,
that
Dr.
briefly. Yeah, so I discussed that briefly in my talk, and I would say that procalcitonin, C-reactive protein, IL-6, and endotoxin. Either of these biomarkers can be very helpful. What we are doing at our unit is routinely C-reactive protein and procalcitonin levels, and we've recently started IL-6. And endotoxin we were doing, but now because of some problems, we are not getting the kits from China. So endotoxin recently we're not able to do, but endotoxin does very well. And especially if you're trying to go for an adsorbent technique where you want the LPS or the endotoxin to be adsorbed, and you want to select what kind of filter you want to use. So if you have both cytokine storm, apart from that, you want endotoxin to be done, it's okay to go with any form of these biomarkers. And I would like any of the other panelists to comment if I have missed any important biomarker in this context.
Dr. Ira, do you have anything to add on?
Yes, unfortunately, of all the biomarkers that Dr. Raki mentioned, in the Philippines right now, it's really procalcitonin, which is available for clinical routine use. The endotoxins, the other biomarkers, unfortunately, are not available. So for treatment response, we rely on procalcitonin and also the usual liver function test, so that we would know if we are aiming, okay, for goal achievement. Okay, hopefully we could have it at a low price in a resource limited country like the Philippines. But procalcitonin, we use it left and right. Thank you.
Thank you, Dr. Ira. Dr. Leng, do you have anything to add on to that?
Okay, for this question, I think maybe we also have a research to observe the biomarkers which changing in the ALS during ALS treatment. But unfortunately, so far we do not have some special biomarkers changes in this ALS treatment. So I think maybe in the future we need the special biomarkers. So I already searched the researches through PubMed. I found that most research is also focused on the such as the TNF alpha, IL-6, but I think all of these set kinds of biomarkers is not very special. So I think maybe we need better biomarkers in the future.
Thank you, Dr. Leng. I see you all three panelists are in agreement with the answer. Can I have a question for you. Sorry. So there was a question posed that some of the patients may be restless when they have ACLF or acute liver failure. So do you sedate them prior to liver dialysis? And if you do, which sedation would you use?
Okay, in my practice, very light sedation actually will do. In fact, in most patients, even a small dose of diphenhydramine or midazolam would work. But some patients who are really very combative, very restless, keeps pulling tubes, out. Okay, sometimes we give them intravenous short-acting IV sedation like Presidex. Of course, we need to monitor always vital signs. But since they are short-acting, very small amount of midazolam, very short amounts of diphenhydramine, usually it will not contribute further to encephalopathy. Of course, in very extreme cases, sometimes we really restrain patient.
All right, thank you, Dr. Ira. The next question comes from Dr. Ken from Malaysia. I think maybe Dr. Raki can take this. So he has been using ALSS for some time. He's quite clear about the timing and the indication, but he would like to know what are the contraindications for ALSS and when you should not use it, and is there any markers or anything to point towards a point of no return where you should stop ALSS for patients who are on the therapy?
Yeah, I feel that's a very important question, and it's a very relevant rather question, because it's very important that we should not be harming these patients, and we should know where we are unnecessarily not burdening them with the increased cost of these therapies. So most important is, if you see your patient in the later phase of the disease, like one of the questions was put up in the patient who was bleeding and was already in a DIC-like state. So if your patient with liver failure has already landed up in that state, this sort of patients is actually a futile group. So here it's okay to go with conservative management, not try any form of liver support therapies, because they will further do only harm and no benefit in such group. And it will be like a salvage therapy where you can use if your patient has shock, which is refractory. So it's okay to use therapies like CRRT or the conventional forms of dialysis. No therapies like what we say plasma exchange or these DPMS or any other fancy techniques. So liver supportive therapies, which are like just filtration based, or this would be enough for such sort of patients.
Okay, thank you, Dr. Raki. Also, may I add to that, Doctor?
Yes,
I
definitely, Dr. Ira.
I read one journal, okay, which basically it's a cart analysis. Okay, they categorize patients into liver failure high risk group and the low risk group, and the high risk group are patients already with hepatic encephalopathy stage 3, stage 4. And based on that analysis, if you institute your DPMS, your ALSS on these patients, benefit might not be as great compared to patients who are just suffering from jaundice, regardless of the bilirubin level. So I think the encephalopathy, the deepening, okay, sensorial change is really not a good sign of 100% benefit. So you might want to think twice when you use a very expensive, well, not really very expensive, but you might want to think twice when you're already dealing with stage 4 hep and ceph, and you subject them to ALSS.
Thank you, Dr. Ira and Dr. Raki. I have a question for Dr. Lang. Again from Dr. Ken. He's posing a situation. He had a case of acute liver failure secondary to anti-TB, and the patient had severe coagulopathy. Upon the insertion of FEMCAT, it was complicated with bleeding, and they had a tough time managing her coagulopathy. They've tried the HA 330 system and the SPAT, but it was futile. So any advice from the panelists? How would you, go about for this patient? Dr. Lang, if you could take this question. Or any of the other panelists can answer as well.
So I think so. I took this up in the, I thought this was the question in the last, because what I wanted to highlight in my talk was in liver failure, it is important if you want to institute any of these artificial liver support therapies and you want the maximal benefit out of it, you have to introduce it early on. Now in early on, you have to see and identify that the patient has failed standard medical treatment. So the patient should not have gone to organ failures, even kidney failure, brain failure, coagulation, bleeding complications, so any of the organ failure. And then if you see the natural history of acute and chronic liver failure or acute liver failure, the bleeding complications are the last in the course of the disease. So that patient is too advanced. So earlier you do these therapies, the benefit is more. The later in the course that you do these benefits, they are mostly like a bridging support or a salvage support. So there you have to see the cost benefit ratio and you have to choose your patients very wisely. Bleeding complications are a real problem. So already if a patient has bleeding complication, it is very, very difficult to do any form of these therapies.
Thank you, Dr. Raki. All right, we have come to the end of our talk of this webinar session. I would ask all the panelists to, could you please summarize a few take-home messages for all our participants? What do you think are the most important things that we should take back home today? Maybe you can start with Dr. Raki.
Okay, so what I would like to say is a brief summary is, yes, we have to identify the right, it is a very, very important and useful therapy while you're managing your patients with liver failure. For acute liver failure, I feel plasma exchange as of now is the best modality. We can combine it with CRRT where we want to achieve ammonia clearance. DPMS has not been studied in context of randomized controlled trials. Looks like an attractive therapy where the patient has gone on to sepsis or other organ dysfunction, where plasma exchange becomes a little challenging. In context of acute and chronic liver failure, I feel it's very, very important that we have to target these therapies in the golden window period. And that's where the patient has not gone into extrahepatic organ failures. We have to repeat these sessions, but if the patient is not having a kind of sustained response, so Normally what we see is after one therapy, you see a response, but again, there is a rebound increase in the parameters. So if it's going on for a while and the patient requires more than 2 to 3 sessions, it is important that you discontinue this and consider a quick liver transplant. Same applies for acute liver failure. You can use then these therapies as a bridging option, but don't try to achieve that you will be able to achieve a complete liver recovery. So quickly reanalyze and change the plan. That is what I would suggest. And we should always consider some form of biomarker as a guidance for considering the intensity of the therapy, how much we need to do in each patient.
Thank you very much, Dr. Raki.
Okay.
Dr. Ira, do you have anything to say? Just
Well,
quickly summarize for us.
yeah, considering the high mortality rate of liver failure patients, I think it is always prudent for us to explore options on how we can improve the survival and the clinical outcome of our patients. Of course, this is on top of the fact that there is a scarcity of organs for liver transplantation. So yes, it's a good bridge to liver transplantation. And again, like Dr. Raki has overemphasized, that the use of any artificial liver support system should be done best when you catch patient during the critical window period. Okay, so let us not wait for a very late situation before we institute any of this liver support system. We need to catch these patients, identify these patients before the therapeutic window is really lost. So thank you.
Thank you, Dr. Ira. Unfortunately, Dr. Lang is not around with us. He's left for an emergency call. So in view of time constraint, I would like to close this webinar session. This has been definitely a very productive and informative session to all of us. I hope we will all now be confident enough to initiate liver dialysis in patients that needs it. Lastly, I would like to thank and extend warm wishes to all our participants and speakers on behalf of Jeffron Biomedical, who made this webinar successful and interesting and engaging. Thank you all. Be safe and hope to meet again in future webinars.
Thank you.